Thank you very much for the kind introduction and for the invitation to present our experience on using the Oncomine tumor mutation load assay. We have been evaluating the Oncomine TML assay for the last 12 months. And the starting point of this project was that published data and conversations with our local oncologists pointed in the direction that TML assessment would be a very important biomarker in the near future. And therefore, we thought about how to approach the introduction of this assay at our institute. And we decided to start with lung cancer as a sort of a paradigm, since based on published data and the conversations, this is the entity in which tumor mutation load might be the first type of tumor in which it becomes most significant in clinical use. So to point out first the background, so the current recommendations by ASCO clearly state that certain biomarkers should be tested in stage 4 non-small cell lung cancer. And this basically refers to the fact that targeted therapies have become available. And for that reason, EGFR, ALK, and ROS testing has become state-of-the-art. In addition, it is recommended that tumors are tested for the expression of PD-L1. And in the case that the tumor cells express PD-L1 in more than 50%, pembrolizumab is recommended as the first-line treatment in this recommendation. In cases in which neither a targeted therapy nor an immune checkpoint inhibitor is recommended, conventional chemotherapy is suggested. This is the current state of the ASCO recommendations. We are all aware that the PD-L1 testing is not a perfect biomarker for various reasons, for technical reasons, for scoring reasons, for the reason that various assays are applied in different types of studies. So it's a very challenging biomarker in daily work. In addition, there are other tissue-based biomarkers which have been suggested to be helpful for stratifying patients for immune checkpoint inhibition. But some of these markers are also challenging, since we often have only small biopsies available to do the biomarker testing in small cell lung cancer. And furthermore, in a significant proportion of patients, we have only cytological material at the time of diagnosis. So this sort of leads to the problem that some of these biomarkers cannot properly be assessed in many patients. This indicates that a genetic biomarker would be perfect in that setting. And one good candidate is for sure tumor mutational burden. And the first indication that this might be a good predictive marker to predict the response to immunocheckpoint inhibitor therapy came from this landmark study by Rivsvi in 2015, who demonstrated in this retrospective analysis that patients who display a durable clinical benefit have a higher tumor mutational load compared to those who don't have a durable clinical benefit during treatment or after treatment with pembrolizumab. And the high tumor mutational burden was also associated with an extended progression-free survival. So this is a retrospective analysis, and subsequently there are a number of prospective controlled trials in which tumor mutational burden was assessed, and these trials were mostly or evaluated the efficacy of nivolumab alone or nivolumab in combination with ipilimumab, and it was clearly demonstrated that there's a close association between tumor mutational burden and the response to immune checkpoint inhibition. In these trials, TMB assessment was performed either by whole exome sequencing or by the Foundation 1 assay. So our challenge now was our aim was to establish an assay which we can do locally. And since whole exome sequencing is beyond, I think, the capabilities of routine diagnostics right now, to make an assay available to our oncologists for stratification of patients. So the aim of this project was to introduce an assay for TMB testing into routine use in a clinical molecular pathology laboratory. And we selected the Oncomine tumor mutation load assay since we were interested in having a commercially available test. Furthermore, we opted for this assay since it can be run on our locally available NGS platform, and by that we were able to complement the test portfolio which we have in place at our institute. So what are the key features of the Oncomine tumor mutational load assay? It's an NGS-based assay, and it comprises the sequencing of 409 genes, which correspond to a genomic footprint of 1.7 MB. And these 1.7 MB contain 1.22 MB of coding regions. The sequencing is sort of done by amplification of roughly 15,000 amplicons. The assay can work with a very low DNA input, and various types of this assay are available. The library preparation can be done manually or automated on a Chef instrument, and on a 540 chip, it's possible to analyze up to 8 samples in one run. So the basic workflow when you use this assay in a clinical setting is as we do it with other NGS-based assays as well. We first select appropriate samples from the archive, or we use cytological material. It's important to enrich for tumor cells to make sure that there is a sufficient amount of tumor DNA in the sample, DNA extraction, library and template preparation, sequencing, primary data analysis, and then there is a specific workflow available in the ion reporter for the TML quantification. And then the next question is which sort of information is put into the report. So the Oncomine tumor mutation load assay uses a specific workflow. We initially started with workflow 1.0. In the meanwhile, we have migrated to the workflow 1.2. And the basic of this workflow is that the primary sequence and data are analyzed for the presence of single nucleotide variants. By comparison with publicly available databases, the polymorphisms are removed, and then the report of the initial analysis provides you various parameters. It gives you the total number of mutations, but it distinguishes also between non-synonymous and synonymous mutations, and it can differentiate between missense and nonsense mutations. And by dividing the number of mutations with 1.22, so this is the coding region, you can calculate a mutational load. So this assay was initially analyzed by Thermo Fisher for various parameters. The first step was to analyze cell lines, and it was demonstrated that the assay is robust and reproducible as far as cell lines are concerned. So these triplets basically resulted in the same numbers, and furthermore, the reproducibility was analyzed also on 10 FFPE samples, and a high correlation was clearly demonstrated. Furthermore, the correlation between the TMB as assessed by the Oncomine tumor mutation load assay and whole genome sequencing was analyzed, and a high correlation was clearly demonstrated in the analyzed cases. So At our institute, we took the following approach. We took advantage of the situation that we had a cohort at hand of 37 nivolumab-treated patients with metastatic non-small cell lung cancer. And due to collaboration with our local oncologists, we had follow-up information of all of these patients. So we retrieved the samples of these patients from our archive. We had 31 formalin-fixed paraffin-embedded samples and 6 cytological samples available of these patients. And then we did the Oncomine tumor mutation load assay analysis. And the result was that we obtained these values, and the range was between 1.6 and roughly 30 mutations per megabase. The median value was 9, and the mean value was 10.2. And in the next step, we compared the tumor mutational load values for patients who qualified as non-durable clinical benefit and those who had a durable clinical benefit. And as you can see here, the median values between these two subpopulations were different, and the difference was statistically significant, and we used basically the same clinical endpoint as in the RISV study. So durable clinical benefit was defined either as complete response or partial response or stable disease for 6 months and longer. After having established this, we extended our cohort of tumors, and up to now we have analyzed 74 non-small cell lung cancers. And in this extended cohort, the median and the mean became slightly smaller, but they are basically in the same sort of range. But it clearly indicates that it depends, or that certain variability does occur depending on the number of patients which we really analyze. And so this is identifying a proper cutoff is a challenge. I think this is one of the conclusions of this data. And the second approach, which we took to put our data into a context, was that we screened the literature for values for TMB, which had been obtained with other assays. So, and as far as the publicly available information is concerned, you can find information on the MSK impact panel, which comprises in the current version 468 genes, and the Foundation 1 assay with 324 genes. So they are sort of in the range of the Oncomine tumor mutation load assay. However, as far as the genomic footprint is concerned, they are significantly smaller. And if you look in detail and score which sort of definition was used for the calculation of TML, there are certain differences. The Oncomine tumor mutation load assay, as we have used it so far, is that we used only the non-synonymous somatic mutations. We did not include indels. This is not the case for the other two assays, so they also include indels. So there's clearly a need for standardization. And if we now compare from published results our mean values with the mean values of these studies, one can see in our extended cohort we had 7.8 as a median, and across all the various histological types of lung cancers, if you calculate the mean of these values, you can come close to the 7.8, and the same holds true for the MSK impact data, which were recently published. So this is where we stand right now, and I think based on these data, we can conclude that in principle, the Oncomine TML assay can be used to analyze tumor DNA obtained from various types of clinical non-small cell lung cancer samples. We have experience with surgical resection, biopsy samples, and cytological samples. And I think the results of our pilot study indicate that the Oncomine TML assay is able to retrospectively identify non-small cell lung cancer patients who may benefit from nivolumab. This is due to the design of our study. When we were doing our evaluation, a number of issues came up, and therefore we would like to recommend future developments which should be clearly addressed in this field. We clearly need a consensus on the TMB definition. There is a need for TMB cutoff values for patient stratification. And since a number of resistance mutations have become known, and I think it's likely that in the near future, additional mutations will become available, which are sort of or known, which are associated with mutations. We would very much like that one can combine the TML assessment with the analysis of certain genes. So variant calling is sort of mandatory, and this would eventually end in a scenario in which a combined workflow is available for TML testing and mutational profiling, which can be used for the selection of targeted therapies. So apparently some of these issues have been found by other people as well, since a new version of the Iron Reporter software has become available, the version 5.10, which now provides information on indels as well. Furthermore, variant calling is possible, and the compatibility with the Oncomine knowledge base reporter software has been created, and the test can now be run also on a 550 chip. So we have no personal experience with this right now, but we are very keen to test this. Finally, I would like to acknowledge the people who contributed to this evaluation project, especially the people at the Molecular Pathology Division at the Institute of Pathology, especially Isadora Demmer, who did most of the work, and the bioinformatics, and the colleagues from the Department of Medical Oncology who provided the clinical information on the patients who were included in this analysis. Thank you very much.